Welcome to a podcast series organized in collaboration with the ACR Centennial Committee as part of our centennial celebration for the American College of Radiology. This three-part series will look at the past, the present, and the future as it pertains to the ACR's work in government relations on policy issues impacting the radiology profession. This particular session will look at the past, and joining us to discuss the rich history of government relations work for the ACR is Dr. Jim Borstead, past chair of the Board of Chancellors and past president of the ACR, and Josh Cooper, vice president of government relations and economics health policy for the ACR. So, because a lot of this predated me, guys, and some of it predated you as well, but I'm going to rely a lot on Dr. Borstead and Josh on your input to give our listeners kind of the background and perspective of where we started with regard to ACR getting involved in government relations work. And from what I'm told, really the first footprint of government relations efforts dates back to getting Medicare payment for radiology services. So if one of you can kind of give us some perspective on process, how that came about, and the importance of that, I think that would be a great place to start.
Well, Ted, thanks a lot. And thanks for including me in this podcast. The thing I want to do right off the bat here is to thank the fantastic ACR government relations staff, because without you, none of the efforts that we're going to discuss on this podcast would have been possible on behalf of our patients and on behalf of our specialty. With respect to the Medicare payment, Medicare and Medicaid, and how the radiologists ended up where they are, Medicare was enacted in the 1960s, and there was a question where imaging and imaging interpretation was going to lie. In other words, would this be with the hospitals under Medicare Part A or under physician services, Medicare Part B? Now, the ACR was instrumental in physician radiologist services being in Part B. And I think that's really important for all of our listeners to know, because otherwise we would have been hospital employees just like the technologists. And then if we fast forward just a little bit, the ACR was also instrumental several decades later in obtaining the acceptance of radiology resource-based relative value scale, the RBRVS, in 1989 through 1982 as this was evolving. There were Medicare reimbursement revisions at that time. Pre that time, we were all reimbursed, all physicians, based on what we usually and customarily charged. And costs to Medicare were going higher and higher and higher. And in the Bush 1 administration, they said, we've got to do something about this. And so they enacted a resource-based relative value scale. But what the ACR was able to do was to enact their own relative value scale within that system. And our specialty was really unique in that regard. And again, that was due largely to the ACR's efforts. So this was very important in our government relations history. Josh, you have any other thoughts about that?
No, other than that was a very good summary of how of an incredibly important issue that was established by the ACR government relations program that has continued forward to this day and has been a benefit to both our patients and our members.
So then if I'm not mistaken, on the heels of that, we had another big effort with the college, and that was going through the process of getting passage for the Mammography Quality Standards Act, MQSA. And I'm wondering if you all can talk a little bit about that, because obviously that was a pretty big deal for us. And even to this day, when we're up on the Hill talking to members of Congress and the staff, I always feel like the one thing that they do know about radiology is mammo. Like that's always kind of the easy thing that we can start with when we have those conversations on the Hill. So if you could kind of talk about the origins of that, I think that could be really helpful background and context for the listeners.
Yeah, Ted, you're spot on, first off. And breast imaging really started in its infancy in the 1960s, but there were a lot of issues with quality and the lack thereof. So we were finally able to get in 1992 legislation that was implemented actually in 1994 with the Mammography Quality Standards Act. The government realized that the ACR, who had been promoting this for a number of years before that, along with a number of other medical societies, that we were really right, that we needed to have quality in mammography. Now, the MQSA really mandated quality for the imaging equipment and the technologist performance. And as I said, the ACR led this effort. Probably the American Cancer Society was another big proponent. And then fast forward the development of BIRADS, where you had really breast imaging reporting. That was the breast imaging and reporting data system. And that was really linked subsequently to the MQSA legislation. And that was a metric for, of course, radiologist performance. And I think this effort is so important for our listeners to understand, because MQSA and BIRADS really exemplifies the ACR statement that quality is our image. And it established the ACR as an organization that promotes quality and radiologists, physicians as promoters of quality care for our patients. And as you said, Ted, when any of us go to the Hill, I mean, the legislators and their staff understands mammography interpretation. And it also, this legislation promoted radiologists as providing direct care to patients, because patients were able to self-refer for their screening mammogram. As I said earlier, quality is so important to the college. Quality paints a tapestry for what we as radiologists do. And woven through that tapestry is this theme of quality. And when you look at BIRADS, for example, as a correlate to the MQSA, now we have TIRADS and PIRADS and LIRADS and everything for liver, for prostate, for thyroid. And this whole system of MQSA and BIRADS really set metrics rather than just subjective ideas of what quality was. It really set metrics to what we are doing and what we must do. So I think this was so important on the part of the college and, again, the government relations staff and the ACR leaders at the time led all this effort.
Yeah, Ted, I would just simply echo Dr. Borgsted's comment on the fact of how by establishing MQSA and enacting MQSA, that really from a government relations standpoint kind of was the standard bearer moving forward on how Capitol Hill viewed the ACR and its government relations efforts. I would also add that in addition to the original MQSA Act itself, there have been several reauthorizations of MQSA, and one of which I remember we were able to amend the Act with lay reports for women. There had been reports of women not being able or somehow not getting the results of their reports. It was either lost with the radiologist or the ordering physician. They wouldn't get them, but this mandated that the radiologist would send a lay report directly to the patient, so that problem would be alleviated. I'd also kind of expound on what you said, Ted, with regard to Congress kind of linking government relations with mammography screening, and the fact that even to this day, we are fighting some efforts, some government agencies, for instance, that want to lessen the guidelines with regard to screening for women and breast cancer. We've been successful in several iterations through appropriations bills to maintain the annual guidelines with regard to women being screened 40 and over. So that's obviously a huge springboard that MQSA provided. And I would also add, Jim mentioned that there were other versions of BIRADS. There are the value of other imaging screening programs, for instance, CT colonography as well as lung cancer screening. I'm sure you can make a direct correlation to their beginnings and their acceptance with regard to the enactment of MQSA.
Yeah, that's great. And it's interesting too when you think about, I think of all the members of ours who are in breast imaging, and all this was predating them, and it gives you an appreciation for how important what was done then and what they maybe take for granted now and never would even think of their life without it. But there was a time that it didn't exist. It's pretty crazy to think how far it's come and how accepted it is. I know when I first started with the college just over 20 years ago, I was actually hired first initially as a state legislative person. And the one issue that was always so hotly discussed and debated, and both internally within our membership and then just with all the other stakeholders and constituencies in the provider community, was self-referral. And so when I think back to our history with regard to self-referral and Stark law, I think that's really important for us to discuss. And I don't know which one of you wants to jump in on that, but it's certainly part of our history for sure.
Well, I can talk about that a little bit, but before I talk about that, I wanted to make one more comment about MQSA and mammography. When I was the chairman of the board, one time I was traveling from Dulles Airport to the college offices, and in a cab, female cab driver, and she and I were chatting, the weather, blah, 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 blah. And when we drove up to the ACR offices, she looked and she said, ACR, ACR, I got my mammogram.
That's great.
This is the impact that MQSA and mammography have on patients, not just legislators. I mean, they understand this, but I digress. I mean, getting back to your question, Ted, we call it the Stark laws. It's the physician self-referral law. And that really was the big proponent of that, I guess, would be Pete Stark from California, who was a representative at that time. That was enacted in 1989, and the college supported that. And what it did was prohibit physicians from referring patients to receive the designated health services, and that included imaging services that Medicare and Medicaid were paying. And there was a prohibition from entities which the physician or family member had a financial relationship. Now, unfortunately, there are some exceptions, and Josh may want to chime in about those exceptions. I don't want to get too much in the weeds here. But again, I mean, the ACR promoted image quality. rather than potentially unnecessary imaging being performed for a physician's financial benefit with that inherent conflict of interest. So this was again an example of the ACR leading in somewhat of a different but similar aspect of quality. Josh, you have any other thoughts about that?
Yeah, I think I'd like to add with regard to the exceptions that you mentioned, Jim. There was one fairly glaring loophole, if you will, in the STAR clause, and I think at the time I don't think many folks thought that other physicians would be able to take advantage of it, but it's known as the in-office ancillary services loophole. And that's whereby any physician can put imaging equipment, advanced imaging equipment, in their office or in proximity to their office. And that was starting to be taken advantage of. And one of the things that came out of that is we tried to, in essence, close that loophole. We were able to nibble a little bit around the edge and we're able to actually garner something of value to our patients. And that is the mandatory accreditation of advanced imaging services. In other words, in order to be paid through Medicare, those who offered those advanced imaging services had to have their equipment accredited on a regular schedule in order to be paid. So again, as Jim mentioned, from a quality standpoint and from an effort to try and narrow that loophole, we were able to enact quality legislation that I think really has made sure that all of the advanced imaging equipment is up to date, is serviced, and the technology is as current as it can be. So again, coming off of the STAR clause, we were able to add a very valuable piece of quality legislation.
Yeah, and Josh, you're spot on, and that was a good comment about the in-office ancillary exemption. And I think what we're trying to do is keep the patient first in all of these government relations endeavors. Anyone can do imaging, but you have to do it with quality. And the ACR to legislators and their staff is the benchmark for quality.
The thing that I think's pretty interesting too, we've been very fortunate over the last several years. Dr. Thorworth being CEO of the college, super supportive of our government relations activities and everything that we've been trying to do. But prior to him, Dr. Harvey Neiman, was CEO, and that was kind of right around the time when I joined the college. And I felt like right around when I joined the college, it was not really, it's kind of more of a random thing than it was like me joining the college and all these things happened, certainly. But it was right at a time when things, it seemed, were getting even more hyper focused on the college with government relations efforts and the value of that to membership and the importance of it, not just to membership, but to people on the Hill and other stakeholders. So going back to Dr. Neiman, because I think it really seemed to start then. Dr. Borst, I know when Dr. Neiman was getting ready to be hired to become the CEO, I believe you were vice chair of the board at the time. And can you talk about thinking back to the vision Dr. Neiman had with regard to the value and importance of government relations? Because really, without the support of having the head of the organization getting us into some of these battles that were sometimes, not cheap, sometimes they were controversial, but they were always kind of, to your point about quality and the patient. Can you talk about that whole process and kind of how that's led us a lot to where we are now?
Yeah. First off, again, this is an opportunity for me to thank all the GR staff and Ted to thank you in particular for all your work. with that GR office, Cindy Moran, Josh Cooper, you, and all the many, many other folks in the on the staff for what you've done. But Harvey did have that vision that we really needed to be closer than, geographically than Reston, Virginia, to what was going on at the Capitol and have an opportunity to be able to meet with legislators and their staff in close proximity. And I was very supportive of that. That happened during my tenure, really, as the ACR board chair, that we established that DC office. And the creation of that office was and is so helpful for what we do. Now, in conjunction with that, then we had the establishment of RADPAC in 1999. And that was really during the leadership of Dr. Max Cloud, one of my predecessors as board chair. And what I'd like to do is talk a little bit about RADPAC, because RADPAC really provides our radiologist leaders with that opportunity to engage with legislators supportive of our issues, and it allows us to articulate our message. And really, that's all we can ask, is the opportunity to meet and to engage. So geographically, you need that office. That's important. But you also need that opportunity. And you all are doing fantastic work in assisting us in that regard. And if you can tee the ball up for us, if you will, then it's the responsibility of the radiologist to hit that drive straight down the fairway. We have to provide the technical knowledge. And it's important for our listeners to realize that the ACR and RADPAC are really a balanced political action committee. We're balanced between Republican and Democrat support. And therefore, no matter which party is in control of which branch of the government, we have those opportunities for engagement. Radiology issues are not just Republican issues or Democrat issues. They cross both sides of the aisle. In fact, I wrote a chairman's column when I was the chairman about just that, that we have to play on both sides. The government relations staff, having that office and having RADPAC, have given us that opportunity.
Yeah, and you were a RADPAC chair, and I feel like you saw many times firsthand the impact that having a DC office, having that presence, having that visibility, building those relationships. So then, to your point, you come in for Hill Day or you go to an event with members of Congress, they immediately know, either the staff here with our government relations office, or maybe you knew them because you had worked with them back in Colorado. But I think it really is a great liaison of sorts. The other thing, too, is that as good as Josh is, and he's one of the best there is when it comes to lobbying, and as good as I try to feel like I try to be with what I do with RADPAC, we're still not radiologists, and we still don't live in Colorado and Florida and all throughout the country, right? We're kind of the hired guns, if you will, and there's so many of us in DC. But I think when we have folks like you, Dr. Borgstead, other leaders of the college, other volunteer leaders, it really makes such a big difference to complement what we do day to day by you guys giving, kind of more like the anecdotal stories. So, well, I was doing a couple of reads earlier today, and let me tell you what happened and why this is important. We could say that, but it doesn't have the same weight and leverage that it would have coming from you, because you're the actual clinician, right? You're the one who's doing it, and you're the ones who's really personally experiencing what the policies are doing to your workflow and your ability to treat patients. So I think that's all great. The other thing I'll say, and then I'll let Josh chime in here too, is because there's been a lot of stuff, especially lately with the toxic environment in DC, I think it is really important for people to understand, like, we're not a Republican PAC, we're not a Democrat PAC. And in fact, I say all the time, Rat Pack has an R and a D in it, and so it just happened, thankfully, that works for the kind of a pun on it, but it's true. You look at something like mammography issues, you have Marsha Blackburn, who's about as far right as you can get, and you have Debbie Wasserman Schultz, who's about as far left as you can get. And they've worked together when Marsha was in the House on some of our mammo screening issues because it wasn't a partisan issue. It was an issue that was important to radiology and to the patients. And so all these things, I think most of our folks know, but it bears repeating, particularly in this environment we're in. Josh, I don't know how much you want to add on to my comments as well as to Dr. Borgsted's about having the DC office, having the support of Dr. Neiman as we kind of got started, getting with the PAC and being a lot more engaged and visible on the Hill.
Yeah, I have a few things to add. Thank you, Ted, and thank you, Jim, for providing that perspective. I agree with Ted. It is definitely important for our members to have that historical perspective on how we kind of have evolved to where we are today. I can tell you selfishly, having been with the college for 26 years now, was very happy when Dr. Neiman made it a high priority to increase our visibility within the College for Government Relations, and also have that translate to increasing our visibility and influence on Capitol Hill. Before Dr. Neiman made those decisions, it was a kind of a one-man show, me being the one-man show. So with his vision, we were able to hire good people like Ted Burns to be the dedicated PAC person, and Ted has done a tremendous job. Very proud of him, very proud of our efforts. We're, I think, consistently one of the leading medical specialty PACs in Washington, D.C., and as we've repeated over and over again, I think it's been an extremely valuable tool to promote our visibility on Capitol Hill with lawmakers. I think, again, kind of moving forward, we've made tremendous progress on the issues we discussed today. We certainly have issues that we are facing today. I will echo Ted's comments with regard to the current political climate. It makes it a little more difficult to have some of our niche issues comparatively moving forward. But again, I think because of the efforts in the past, because of our ability to be associated with quality and thoughtful solutions, the ACR is in a tremendously great position to move forward with many of its issues.
I think we're pretty close to the end of this discussion, looking back at the college's efforts, kind of where it all began and kind of how we got to where we are now, and then obviously looking forward to the future. The one thing I want to end on is that, Dr. Borsa, you were such a enthusiastic and just so supportive volunteer leader, again, with RADPAC and with the college as a whole. I think when my career with ACR is done, whenever that is, probably biggest regret I'll always have is I was never successful to get you to run for office, because while you probably would have been miserable in office, given how things are in Congress, man, you would have been a great member of Congress. And we always said that you would come to the booth and we would have conversations with you, and you'd walk away and we would all say, how do we get him to run for Congress? How do we make that happen? And I know I've teased you a lot about that in the past, and maybe it's a silver lining for you that you never did, but you were really one of our best advocates, and we spent so much time together over the years, and we really do value and appreciate all that you did for us. Because again, no matter how good Josh is, no matter how good I try to be, we really need folks like you to kind of help us help our membership. And so thank you for all you did in the past.
Well, you're very kind, Ted. But I think there's a couple things as we close that I'd like to emphasize too. We haven't talked much about the GR office's state efforts, and it's important for our members to realize that we do more than just national legislation. I mean, and in Colorado, we got so much help. We have had so much help over the years from the ACR on state issues. The ACR GR staff is a tremendous resource there. That's important. And just one closing story about quality. When my daughter was pregnant for the first time 20 years ago, she went to get her ultrasound exam. And she called me up and she told me she'd had the exam. And she says, "Dad, I know that was a quality exam because I saw the ACR plaque on the wall and Dr. Cloud had signed that plaque." And she knew Dr. Cloud. This whole issue of quality permeates right down to the patient. It's not just theoretical amongst physicians and legislators. So again, thank you all so much for what you've done and what you continue to do.
Well, thanks everyone. Thanks, Dr. Borsted. Thanks, Josh, for again kind of painting the picture of kind of our efforts and struggles and challenges over the years. And then obviously we have a whole bunch remaining as we move forward, but we welcome those challenges and look forward to working with everyone listening in accomplishing those goals. So thanks everyone for the talk today.
Thank you.
Thanks, Ted.